Okay. So welcome everybody. On behalf of Ticonderoga Emergency Squad, I want to thank you guys for coming and taking this training. I understand that we've got a bunch of people from Keene Valley on tonight. I'm excited to see that. I hear that you guys are going to be starting this project as well. Other than Ticonderoga and Keene, the only agency in Essex County that's running nitrous oxide right now is Wilmington. We were able to get resources from Wilmington. They were very helpful to help us institute this program. So we're very excited to be starting this. I'd be remiss if we didn't mention our grant funding and our medical director throughout this. So we purchased two nitrous oxide systems from Henry Schein Medical. That's the sole provider of nitrous oxide systems for EMS that we've found thus far. And we didn't really have it in our budget to go and purchase a nice little toy like this. So thanks to the Cloud Splitter Foundation, Walmart here in Ticonderoga, and Silvamo, they are our paper mill in Ticonderoga. We were able to get grant funding, secure that, and we were able to purchase these two. Throughout the process of creating this program, we received guidance and approval from Dr. Wiseman, and quality assurance is going to be continuing throughout this course. So just as a little intro to what we're going to be doing tonight, we're going to go through all of the actual pharmacology of nitrous oxide. I think if we're going to be instituting a new medication, we really need to understand what we're doing with this medication, how the medication works, and everything that we need to be watching out for. We're going to talk a little bit about some of the administrative stuff on that end. So this can be something that your agency can base this information off of. And then finally, we're going to take a look at the nitrous oxide system. I'll show you guys that system and how it works. So we're talking about nitrous oxide, obviously, right? That's why we're all here. So nitrous oxide is a colorless gas, and it's classified as an inhalational anesthetic, an analgesic, and an anxiolytic. So it can produce anesthesia, although we are very unlikely to find full anesthesia in the EMS setting with this medication. We're obviously going for the analgesic effects, dealing with pain. But one of the small little things that is a great property of this medication is that it gets rid of the anxiety. So that's really important for us to keep in mind as we're using this medication and thinking about who we can use it on. There's a lot of different names for nitrous oxide. Obviously, we know it scientifically and medically as nitrous oxide or N2O. This is also a recreational drug, okay? So recreationally, it's known as laughing gas. It's known as nitrous, NOS, or whippets, right? So those little spray cans of whipped cream when you're doing whippets, that's nitrous oxide. Okay, so we also have to keep in mind that this can be a recreational drug. We have to take some precautions against that. When we think about air composition, right, getting into the chemistry of this medication a little bit, we understand that nitrogen is 78% of ambient oxygen or ambient air. Oxygen consists 21% of our ambient air. So nitrous oxide is a combination of two nitrogen atoms binding together with one oxygen. So we get N2 and then we get O, right? Giving us nitrous oxide. We inhale nitrous oxide. So this is not going to be an IV medication. This isn't an IM medication. This is going to be an inhaled medication administered as a gas. It's going to be a 50-50 mix of nitrous oxide and oxygen. There is no way for you in EMS to change the concentration of nitrous oxide that your patient is going to be delivering. It's going to be a set 50-50 mix with this system. It's factory set. There's no way to change it. And we're going to deliver this either via a mouthpiece or via a tightly sealed mask. So if you're administering this medication with a tightly sealed mask, and this will fit right onto a CPAP mask that you can then have the patient use, Then you're going to be delivering an FiO2 of 50% because we're going to increase the oxygen concentration from 21% to 50%. And then we're going to increase the FiN2O up to 50%, up from 0%. Most of the nitrous oxide is going to be eliminated completely unchanged in the lungs. So we're going to breathe it in, we're going to breathe it out. However, there is going to be some nitrous oxide that will also diffuse through the patient's skin. So it will be eliminated that way. And there's going to be some of the nitrous oxide that's going to be metabolized by anaerobic bacteria in the gut. But again, the vast majority of this medication is going to be coming back out through the lungs. So how does nitrous oxide work? Well, we don't really know. All right. We don't understand this medication has been around since the 1800s, but we still don't understand exactly how nitrous oxide works. There's a lot of working theories, though. So for the anesthesia end, the thought is that it inhibits NMDA receptors. It also is found to stimulate dopaminergic receptors and alpha-1 and alpha-2 adrenergic receptors. So we're going to have a little bit of a sympathetic effect with this medication. Also stimulates the release of endogenous opioids. Okay, so you're going to have endogenous opioids throughout your body at any given time. Right now, you've got endogenous opioids running around in your body. Not a lot, though, right? So nitrous oxide is thought to actually stimulate the release of those endogenous opioids and stimulate opioid receptors. And that's believed to be the mechanism behind analgesia. Now, interestingly enough, if you were to administer nitrous oxide to a patient and then administer naloxone or Narcan to that same patient, they would no longer have the analgesic effects. You would eliminate those analgesic effects. It would not do anything else on that medication. So any of the other effects that the patient is experiencing, they're going to continue to experience. So if you were to say, provide some respiratory depression, although that's incredibly rare with this medication. But if that were to happen, you can't just give some Narcan and hope that it's going to get better. It's not going to work like that. The patient's just going to start experiencing pain. And then it's also thought to activate GABA-A receptors. And that's going to be a very similar mechanism to benzodiazepines and alcohol. So that's believed to be the mechanism behind the anxiolysis of this medication. There's a whole bunch of psychotropic effects of nitrous oxide. Psychotropic meaning affecting the mental state. When we're administering nitrous oxide, that's what we're shooting for. We're trying to induce the psychotropic effects of the medication. So some of the psychotropic effects, again, analgesia and anesthesia, right? So we're going to be going for the inability to feel pain and the temporary loss of sensation. Now, it should be known that nitrous oxide is a rather weak anesthetic. And again, in the EMS setting, with that concentration of 50-50 that we're going to be giving, it's very unlikely that we're going to produce anesthesia with this medication. Typically speaking, when nitrous oxide is used in the operating room, it's used in conjunction with another anesthetic. So oftentimes it's used to help other inhalational anesthetics get deeper in the lungs, or it's used to potentiate the effects of other medications. Again, it produces anxiolysis, so we're going to reduce anxiety. It will produce euphoria, so our patients will oftentimes get a feeling of intense excitement and happiness, hence the name laughing gas. And it can produce dissociation. Now, dissociation is a weird topic and it can encompass a whole lot of different things, but it's described as a disconnection and lack of continuity between thoughts, memories, surroundings, actions, and identity. So we may be able to dissociate our patient a little bit by giving them nitrous oxide, kind of similar to the action of ketamine. The respiratory effects, nitrous oxide decreases the tidal volume. However, it increases the respiratory rate. So although we're decreasing tidal volume, with that increased rate, we're typically going to maintain a good minute volume. That's not really going to change. So to see respiratory depression with nitrous oxide is rather rare. However, it is going to reduce the person's ability to respond to hypoxia and hypercapnia. So if you have a patient who's hypoxic or hypercapnic, let's say they are having a COPD exacerbation or something like that. They're hypoxic and they've got all that carbon dioxide building up in their blood. Our patient isn't going to be able to compensate as well if we give them nitrous oxide. It's not going to be a great medication to give to somebody who's having respiratory distress. Nitrous oxide also depresses myocardial activity. So this is important if we have somebody who's potentially experiencing a cardiovascular problem. We don't really want to depress the myocardium even more. However, it does increase the central sympathetic outflow. So we know that nitrous oxide stimulates our alpha-1 and alpha-2 receptors a little bit. So it's going to increase our heart rate a little bit. And that means that we're going to have a negligible change in cardiac output. We're really not going to have issues with cardiac output, and very rarely are we going to have really much of a change in blood pressure. Most likely, if you're going to see a reduction in blood pressure when giving this to a patient, that's going to be because you have taken care of their anxiety and their pain, and their blood pressure comes down a little bit because of that. It does cause vasoconstriction in the pulmonary capillary beds. What that means is that it's going to increase the blood pressure in the lungs and increase the pressure in the heart. So if we have somebody who already has a condition called pulmonary hypertension, which is caused by COPD, by congestive heart failure, by pulmonary emboli, if we have somebody who has pulmonary hypertension, we don't really want to give this medication to them because it's going to vasoconstrict the pulmonary capillary beds and increase the pressure there even more. It's also going to lead to some vasoconstriction in the liver and kidneys. So we are going to get a little bit of reduced blood flow into those areas. Not a great medication if they have some kind of failure, like renal failure or hepatic failure, but usually not going to be a really impressive change. It also has some non-psychotropic central nervous system effects. So with that increased sympathetic outflow, it's going to increase cerebral metabolism. Okay, so our cells in our brain are going to start burning more glucose, more oxygen. In response to that, our body is going to increase the blood flow going to the brain. And if we increase the amount of blood going to the brain, that means that we're going to increase the intracranial pressure. So nitrous oxide is known to increase intracranial pressure. If we have somebody who already has an increased intracranial pressure, such as a patient who's got a hemorrhage or a tumor in their brain, this isn't a great medication to give them because we're going to further increase ICP. On the neuromuscular end, it's going to increase skeletal muscle activity, and that is going to also affect the sympathetic outflow to the muscles. Okay. What this translates into is that with patients receiving nitrous oxide, we'll oftentimes see some shivering or some tremors start in because of the amount of sympathetic activation of that skeletal muscle. Now, there are quite a few adverse effects that we have to at least touch on. I'm going to explain how these adverse effects act and what we need to consider when we come across these. So nausea and vomiting, expansion of air-filled spaces, you guys can rate this. There's quite a few that we at least need to talk about how we can address those. So as far as nausea and vomiting, we don't know the exact mechanism for the nausea and vomiting that occurs with nitrous oxide. Some of our suspects include dopaminergic activation, an increased middle ear pressure, and bowel distension. Those last two are due to the diffusion into air-filled spaces. We're not really sure which of these is usually going to be the cause of nausea and vomiting. What we do know is that it's more frequent in females and especially in children. So keep that in mind when you're giving nitrous oxide, that nausea and vomiting may very well set in. So if we have a patient who becomes nauseated or they start vomiting with nitrous oxide, our first step is, okay, stop giving them the medication that's making them nauseated, right? Stop giving them nitrous oxide. Seems like common sense, right? If you're an AEMT, then you guys can provide some isopropyl alcohol aromatherapy. We're not really sure what the mechanism behind this is, but we do know that it's more effective than Zofran in quite a few studies. So have the patient smell an alcohol pad, and oftentimes that will take care of a lot of the patient's nausea. If you're a critical care or a paramedic, you could either give some Zofran or ondansetron, so 4 milligrams of Zofran. And the mechanism behind Zofran is it blocks those serotonin impulses from the gut to the vomiting center in the medulla. So that would affect the dopaminergic activation that could be causing the nausea. If you think that it's increased middle ear pressure, then you could go ahead and give 25 milligrams of Benadryl or diphenhydramine. Diphenhydramine inhibits histamine transmission from the ear to the nausea center of the medulla. And so that would be a better medication if you suspect increased middle ear pressure. Or if the patient has motion sickness, Benadryl is going to be a much better medication than Zofran is for the treatment of nausea. So those are our options, but again, just stop the nitrous oxide if they become nauseated and then treat the nausea. Now, expansion of air-filled spaces is a really important one that I want you guys to keep in mind. If you're to take any of the adverse effects away from this training, I want you guys to really understand the expansion of air-filled spaces, because this is an area where you can absolutely cause harm with nitrous oxide. So here we have in our little red box, we've got our blood vessels, right? And then we also, around that, have some kind of enclosed free air somewhere in the body. This could be a pneumothorax. This could be an air embolism. And so we've got a bunch of nitrogen in that free air space. What happens is we bring our nitrous oxide down along, and our nitrous oxide diffuses into that free air cavity. All right, so that doesn't seem like that big of an issue. If we're putting nitrous oxide into that free air cavity, no big deal. We just would diffuse all of that nitrogen out. So kick the nitrogen out and no harm, no foul. We're just replacing the gas that's in that area. Here's the problem. Nitrous oxide is 30 times more soluble than nitrogen is. So it diffuses much quicker. So that nitrous oxide is absolutely going to go into that free airspace, but the nitrogen isn't going to leave that quickly. The nitrogen is just going to hang out in there, and we're going to increase the amount of gas in that air-filled cavity. That's going to cause that air-filled cavity to expand. you could potentially double the size of a pneumothorax just by giving somebody nitrous oxide. So this is a very dangerous place to go. You could absolutely tip the scales from a simple pneumothorax to a tension pneumothorax and cause great harm to your patient if you do this. So when we think about any kind of ability for there to be an air-filled space within the body, obviously the first thing as AEMTs, critical cares, or paramedics that we think about is a pneumothorax, right? So pneumothorax, that collection of air between the visceral and parietal pleura of the lungs. This could cause that to increase in size and cause it to tip that scale from simple to tension pneumothorax. We also have our thoughts on an air embolism. So an air embolism being a gas bubble in the vasculature. We might see this because, hey, you didn't flush your J-loop before you started an IV and you injected air into the patient, which is super dangerous. Make sure that you don't do that. Or maybe our patient has a laceration on the neck or into one of the large blood vessels, and we've got bleeding controlled, obviously, before we give nitrous oxide, but maybe some air got up in there, and now you've got some air that's hanging out in the patient's blood vessels. This is going to increase the size of this, and that could lead to an actual occlusion. So that could lead to a stroke or a pulmonary embolism or an MI. Along with air emboli, we have to think about decompression sickness. So in decompression sickness, nitrogen is going to dissolve, and we're going to start developing bubbles as our pressure decreases. So we're going to have a bunch of air emboli, essentially. Again, we can make this much larger. Pneumocephalus is going to be a collection of air within the cranial cavity. Risk factors for this are going to include a recent brain surgery. So obviously, if somebody just had like a tumor removal, they've had brain surgery, or maybe somebody had a hemorrhagic stroke a few weeks ago and they drained the blood from it. They had to take part of their cranium off to drain the blood from it. And now they've got a little bit of air that's going to be sticking around within the cranial cavity before it gets absorbed by the body. You could increase that size and increase the intracranial pressure. The other really big one that I want you guys to keep in mind here is intestinal obstruction. Now, anybody who's worked in an ER knows that oftentimes when somebody comes in with abdominal pain, they've got some level of an intestinal obstruction, right? Oftentimes that's how it goes. The problem is that air builds up behind that intestinal obstruction. So if you were to give your patient who's got abdominal pain, and we can't really well differentiate abdominal pain in the field, you've got a patient with abdominal pain and they've got an intestinal obstruction, then you can increase the intrathoracic pressure. So that could actually lead to pressure on the diaphragm, make it hard for the patient to get full expansion and really decrease their tidal volume. It could actually rupture the intestines. And it would cause difficulty closing those intestines during surgery if they have to go in and remove that obstruction from the intestines. So you need to take great caution when you administer this medication to anybody who's got abdominal pain, because at the end of the day, we don't know if they have an intestinal obstruction. And that very well could be the case for why they're having pain. Intraocular gas, if somebody recently had eye surgery, they could have some gas within the eye. This could lead to blindness and pain if you give them nitrous oxide. Or if somebody recently had surgery of the middle ear, then you could disrupt the ossicular chain. You could cause nausea or vomiting. And if they have any kind of grafts in their ear, you could disrupt those by giving nitrous oxide. So just pay attention, make sure that you get a good history from your patient. Make sure that you get a really thorough assessment, listen to lung sounds. This isn't a good medication when you've got somebody who's in a major trauma situation, because you can make them much worse. Another effect that we have is this thing called diffusion hypoxia, also known as the second gas effect. So we've got our little alveoli, we've got our pulmonary capillary, and our little yellow bubbles are going to be nitrogen, green is going to be oxygen, and N2O, or blue, is going to be nitrous oxide. So we're administering a 50-50 mix of oxygen and nitrous oxide to our patient. So we've got equal amounts of oxygen, nitrous oxide. We don't have any nitrogen in there, right? Because they're just breathing in those two gases. Here's what happens is we have nitrous oxide that's returning to the lungs to be eliminated, and we've got nitrous oxide that's sitting in our alveoli. So all of that nitrous oxide is going to go ahead and that's going to diffuse into the pulmonary capillaries. Our oxygen is going to diffuse into the pulmonary capillaries, and that's going to leave to go out to the body. And then we turn off our nitrous oxide. Okay, this is what happens here. We turn off our nitrous oxide, and our patient just starts breathing room air. So now they're at 21% oxygen, 78% nitrogen, just breathing room air. All of this nitrous oxide that was coming back to the lungs to be eliminated is going to come through, it's going to diffuse into those alveoli. And we understand that nitrous oxide diffuses much quicker than nitrogen does. So that nitrous oxide is going to come back, get into the alveoli, and we're going to fill those alveoli. All right. At this point, we've got so much gas between nitrogen and nitrous oxide and oxygen sitting in there that alveoli is fully expanded. It's completely full. And that nitrogen isn't leaving, right? It's not going to leave as quickly as nitrous oxide does. This is going to dilute the amount of oxygen that's sitting in the alveoli, because we still only have 21% oxygen at this point. We've got a whole bunch of nitrous oxide, a whole bunch of nitrogen sitting in the alveoli. So our oxygen is diluted. This can lead to hypoxia. Okay, this is occurring when we turn off the nitrous oxide. This is when we take the nitrous oxide away from the patient, that we can promote hypoxia. Now, this is of a very short duration, and you might not even see it. This is going to last less than 5 minutes, that the patient is going to be hypoxic at the termination of nitrous oxide therapy. So to prevent that from occurring, when you take the nitrous oxide off the patient, or when the patient takes the nitrous oxide off themselves, I should say, give them a non-rebreather. Give them a non-rebreather for 5 minutes, give them 100% oxygen for like 5 minutes, and now you don't have to deal with diffusion hypoxia, because you're just going to increase that FiO2. The oxygen isn't going to become diluted because there's a ton of oxygen in the alveoli, and it's not a big deal. And you don't have to do it all the way to the hospital. Again, this is of 5-minute duration. So just give them some oxygen for like 5 minutes, and they'll be good to go. Again, we know that nitrous oxide is going to produce cerebral vasodilation and sympathetic stimulation. It's going to increase the intracranial pressure. So don't give nitrous oxide to anybody who potentially has intracranial bleeding. So this is any undifferentiated stroke. Until they get a CT scan, you shouldn't be giving it to them, because they could have a bleed. Right? You got somebody who's complaining of a terrible headache. Nitrous oxide isn't the medication for that patient until they get a CT scan and rule out bleeding. If our patient has any kind of brain, skull, or spinal cord cancer, they're going to inherently have an increased ICP. If somebody has a shunt or a fistula, right, to drain CSF, and that potentially is plugged, or even if they have it, then they're probably not a great candidate for nitrous oxide. Don't give it to anybody who potentially has an increased ICP. Nitrous oxide is very rarely going to cause respiratory depression on its own. However, it is going to potentiate the action of other CNS depressants. So if your patient's intoxicated on alcohol, you've administered opioids or benzos or ketamine to this patient, then you need to keep a really close eye on the respiratory status, just because nitrous oxide in combination with that other medication may cause respiratory depression. Okay. Make sure that you've got SpO2 on them, make sure that you've got end-tidal on them, and make sure that you're directly visualizing the patient, making sure that they're breathing adequately. This isn't the time to go and be sitting in the captain's seat doing your chart if you're giving this medication to the patient. Nitrous oxide also causes vitamin B12 deficiency. And you guys are all probably like, I don't care, it's vitamin B12. This is important, okay? So I'm gonna tell you the mechanism behind it. I'm gonna tell you what the effects are, and then I'm gonna tell you when you actually need to pay attention to this. So nitrous oxide oxidizes the cobalt in vitamin B12, and that means that the vitamin B12 and folate metabolism will be inhibited. This will lead to a cobalamin or vitamin B12 deficiency. Now, the effects of a vitamin B12 deficiency include decreased hemoglobin production. Okay, so we're going to potentially cause some anemia with this medication. It's going to inhibit gene methylation, which causes cancer. Now, this isn't I gave somebody nitrous oxide in the ambulance for a quick amount of time and now they have cancer. This is, okay, long-term, a lot of exposure to nitrous oxide could potentially cause cancer. So this is more of an occupational exposure risk, where if you're giving nitrous oxide to every single patient, and you're giving nitrous oxide to every single patient every single day, and you're not ventilating your ambulance well, and you're getting nitrous oxide, you're breathing it in as well, it could be a carcinogen at that point. It can lead to inhibition of myelin production. So myelin is that protective sheath of the nerve cell. So it could lead to some neuro effects. Again, that's a really long-term effect. And it can decrease fetal DNA synthesis. So that top one and that bottom one are going to be the really important ones that we need to keep in mind. Okay, so we don't want to give this medication to anybody who's critically ill. Anybody who's critically ill, critically injured, we don't want to give them nitrous oxide because we really don't want these patients to have a vitamin B12 deficiency. It could produce anemia or make anemia significantly worse. It's also going to be contraindicated in the first trimester of pregnancy. So up to 13 weeks of pregnancy, we don't want to give this medication because that's when fetal DNA synthesis is really super important. So we don't want to give it during that first trimester. The second and third trimesters, there's not a lot of great studies out there, but it is considered to be relatively safe for that second and third trimester of pregnancy. Maybe not the first medication that you're going to give to that patient, but it could be an option. But if their first trimester pregnancy, do not give them nitrous oxide. There is a potential to produce a hypoxic mixture. So if the NitroNox system were to fail, you could deliver an FiO2 of less than 21%. Now, again, the system is preset to a 50-50 mix of nitrous oxide and oxygen. And there's alarms, okay? It's going to alarm when your oxygen concentration gets low. So pay attention to alarms. If the patient is alarming, then you need to take it away from the patient. Don't ignore the alarms. Your first step, if it alarms, is to take it away and then give them some oxygen if they need it, continue SpO2 monitoring. And after you take it away from the patient, you can try to figure out what is causing that issue. Maybe the D tank that you were hooked up to ran out of oxygen. Could be a potential issue. There's a risk for occupational exposure to nitrous oxide. So in an enclosed environment, nitrous oxide is going to build up in that atmosphere. Now, would you agree that an ambulance is an enclosed environment most of the time? I would say so, right? Nitrous oxide is colorless. You're not going to see it, and it has a sweet scent. So if you start smelling things that are sweet, maybe you're being exposed to nitrous oxide. If you're exposed to a significant amount of nitrous oxide, then you will start feeling the effects. You will start feeling all of those psychotropic effects as a provider. And I don't know about you guys, but I don't want my EMS provider taking care of me to be sitting there in a state of dissociation and euphoria, just giggling at everything and not actually taking care of me. So we need to take some steps to reduce occupational exposure when administering this medication. Masks are not going to be effective. Nitrous oxide is a gas. And if we've learned anything from the past couple of years is that we can wear masks and still breathe and function, right? It's not going to prevent the nitrous oxide from getting into you. Obviously, you should be wearing a mask right now, but it's not going to prevent that exposure. What you do need to do is open the windows in your ambulance. I know that that's a luxury not every ambulance has, but if you've got windows that open in your ambulance, then open those and turn on the exhalation fan. I don't think I've ever been in an ambulance that didn't have an exhalation fan in the back. Turn it on, and that way the nitrous oxide that the patient eliminates diffuses through that fan. We have to talk about recreational use when we talk about nitrous oxide. Nitrous oxide is not a controlled substance, okay? Not classified as a controlled substance in the United States, but it is a known drug of abuse. So, despite the legal standing of it, at least for our agency, we are treating nitrous oxide similarly to how we treat all of our controlled substances. So our ketamine, our fentanyl, our Versed, all of that fun stuff, we're going to be treating it in a very similar manner. We're keeping it double locked, we're keeping it tagged, we're going to be watching weights of it. So you need to withhold it from public access when you're not using it. We're going to be keeping it in a locked container with a recorded breakaway tag. That breakaway tag, we're going to record anytime we open it, what we're doing with that nitrous oxide. And that way we know, hey, that breakaway tag got broken, or why is there a new tag on it? We at least can figure out who got access to it and why. If there's any kind of unauthorized access, theft, or use, it should be reported to agency leadership and law enforcement. So our policy and tie here is if somebody were to get into our station or get into our ambulance and start accessing our nitrous oxide, we obviously would let the operations manager and the assistant operations manager know, and we'd call law enforcement because the patient is, or not the patient, but whoever's trying to steal it from us is breaking into our building or our ambulance and taking it and stealing it from us. You know, I firmly believe that we should always keep our ambulances locked. I know that's a rarity up in the North Country, but that's just my opinion. I think that ambulances should be locked at all times, anyways, to prevent theft of anything, including the ambulance. As far as staff, we should only be giving this medication to patients when it's medically appropriate to give it to patients. It's completely unacceptable, and it's not tolerable for your staff to be using agency medications for recreational use. Obviously, this isn't something that is kosher, right? So there's a lot of different consequences of the inappropriate use of nitrous oxide. At least for Thai EMS, you could be suspended, you could be terminated from the squad, absolutely will be referred to the Department of Health, and you can lose your EMS certification for misusing nitrous oxide, and you could potentially be prosecuted. So, wait, you can get your cert taken away? Yeah, absolutely. So this is Part 800, the Emergency Medical Services Law, right? So Part 800 has this little fun thing, the suspension or revocation of EMS certification. So the Department of Health can at any time censor, reprimand, fine, revoke, or annul your certification at any time. And some of the reasons that you can do that they could do this as related to nitrous oxide, if you respond to a call, provide patient care, or drive an ambulance or other emergency vehicle while under the influence of alcohol or any other drug or substance which has affected the certificate holder's physical coordination or intellectual functions. Okay? Nitrous oxide absolutely is a substance, it's a drug that can affect your physical coordination and intellectual functions. State can absolutely take your card away. And for agency leadership, this is a mandated report to DOH. If you have any kind of suspicion that any of your members responded on a call under the influence of drugs or alcohol, you are mandated to do a DOH report. You have to do it. So this can lead to a whole lot of issues. Additionally, you can get your cert taken away if you misappropriate any money or any property from any source during EMS duty, even if it's not prosecuted as a crime. So even if you don't have law enforcement issues with it, the state can absolutely take away your cert because you stole your agency's property by using the nitrous oxide. This is not something to screw around with. This isn't something to be playing with. Don't be using your agency's nitrous oxide. We know the nitrous oxide is teratogenic. So teratogenicity is the ability to cause defects in a developing fetus. It's an FDA pregnancy class C. So that means that there's insufficient human studies, but animal studies show fetal harm. This potential harm is related to the ineffective folate and vitamin B12 metabolism, as well as the alpha-1 adrenergic stimulation, so that sympathetic stimulation. It's going to be, the harm is really especially prevalent in the first trimester of pregnancy, so that's when you should be avoiding giving nitrous oxide. There are some environmental concerns that some may be worried about with nitrous oxide. So nitrous oxide is a greenhouse gas. It contributes to global warming. Nitrous oxide itself constitutes approximately 5% of greenhouse gases, and less than 1% of the environmental nitrous oxide is the result of anesthesia. So less than 1% of that 5% is actually the result of medical administration of nitrous oxide. So yeah, it's something that you can keep in mind. However, this isn't a huge contributor to global warming when we're giving it in an ambulance. Some adverse psychotropic effects, it can cause hallucinations. Not a great medication to give somebody if they're already having hallucinations. It can produce amnesia or the loss of memories. It can produce analysis suppression. So our patient may not be able to make good decisions after we give them nitrous oxide. This isn't like, I'm going to give you some nitrous oxide and sign you off. They're not going to be able to make that decision at that point. It can cause laughter fits, which are probably just going to be amusing, but they could be an issue. And it can cause synesthesia, or the mixture of the senses. So that essentially says, I can hear that grass, or I can smell this music, right? And that's a mixture of the senses. Some other miscellaneous side effects, it can cause a headache, dizziness, paresthesia, or abnormal sensations. It can decrease our patient's visual acuity or produce double vision while they're under the influence of the medication. It can cause them to be fatigued. And due to that sympathetic outflow, we oftentimes will see shivering and maybe even some diaphoresis. So these are all going to be normal side effects of this medication. Again, you should understand that with any medication, the effects are going to be dose dependent based on the individual and their medical condition. There's the potential for other side effects or idiosyncratic reactions. That's going to be the stuff that's documented that I was able to find that I told you guys about. There's always the potential that your patient could have a different side effect. So you just need to understand that and be able to correlate any kind of side effect the patient has to the medications that you gave them or their medical condition. You can't change the mixture of nitrous oxide and oxygen that you administer to the patient, so the length of administration determines the ultimate dose that the patient gets. Timing of this medication, the onset is 30 seconds to 3 minutes. This is a very quick onset medication, but it only lasts about 5 minutes. So the patient's going to get it quick and they're going to offload it quick. This is going to be very, very short acting. It is our most short acting medication that we can give a patient. Our indications for use obviously include pain management. We could consider it for procedural sedation, for labor pain, or for anxiety. Okay, just something to consider, right? So this is our adult pain management protocol in New York State. So for adults, AEMTs can administer nitrous oxide. And when I say administer, I mean you can set up the system and then your patient is going to self-administer the medication. So they're going to hold the mouthpiece, they're going to hold the mask, and we're going to administer this medication for as long as they need. So they're going to take it for as long as they need to, for pain management. They may take it off, put it back on, anything like that, or until the patient drops the mask or the mouthpiece. For pediatric pain management, we also have this built in for pediatrics. Okay, so AEMTs can administer nitrous oxide to our pediatric patients. So I want to break down kind of my thinking when it comes to pain management, because I know that we're going to be, you know, for any agency that gets this, this means that critical cares and paramedics are going to be carrying it. So I think that it's important for us all to consider, where does nitrous oxide fit into our pain management? Who is it a good patient for? When are we using it? So for the EMT, no matter what kind of level of pain there is, they can provide verbal support, splinting and positioning, and hot and cold packs. They really don't have any other pain management options. Going up to AEMTs, obviously AEMTs have acetaminophen and ibuprofen that can be administered for mild to moderate pain. We're not really just going to give somebody Tylenol when they've got severe pain. Critical cares, for that mild to like less severe pain, you got ketorolac or Toradol. Or for that really severe pain, there's fentanyl, there's morphine, or potentially as a med control option, you could call for some midazolam. I've done that quite a few times for people who have like spasmodic pain from fractures or stuff like that. You know, Versed could absolutely be helpful for those patients, but it's not built into our pain management protocol all right then and there. You'd have to call med control for that. And then our paramedics, again, medical control. We've got ketamine in our med control options for pain management. We could administer some ketamine. Here's where I feel that nitrous oxide fits in. This isn't going to be for the most severe pain, all right? This isn't just a replacement for opiates. Sometimes we're going to have to administer fentanyl or morphine to our patients. But nitrous oxide could be very useful for those who have a little bit more severe pain than, say, our acetaminophen or ibuprofen group. It's going to be useful for those people, but it's not for the most severe pain. I think that this is really a middle of the road medication for somebody who's got, let's say, like anywhere from like a 4 to 7 on 10 pain scale. This is usually where, okay, yeah, I'd probably give them that medication. We also should think about our timing of all of our medications and how that's going to fit in on the timing level of it. So for AEMTs, you've got oral acetaminophen and ibuprofen. The onset of those medications isn't for 30 minutes. You can't give somebody Tylenol and expect them to have pain management 5 minutes later. That's not how it works. It's going to take 30 minutes for them to actually get any kind of analgesic effect from it, but they are long acting. They're going to last a few hours. For our critical cares and paramedics, Toradol, again, no matter if you give it IV or IM, it's going to have a 30-minute onset. You're not going to get pain management from Toradol 5 minutes after you give the medication. It takes 30 or so minutes for that medication to actually cause the effect. But again, just like acetaminophen and ibuprofen, because it's an NSAID, it's going to last quite a few hours. We've got IV fentanyl, which can come on in about 30 seconds. Usually takes a couple of minutes, but you can have 30-second onset of pain management, and it's going to last up to 30 minutes when you give IV fentanyl. Our IM or IN, so intramuscular or intranasal fentanyl, that's going to take about 5 to 10 minutes for it to come on, and it can last close to an hour when you give that medication that route. But again, it's going to take a little while. It's not going to last too incredibly long. Our morphine, we know, takes a little bit longer to set in, but it's going to last a little bit longer than fentanyl. So it takes about 5 minutes for IV morphine or 15 minutes for IM morphine to set in, and they're going to last about an hour. Our ketamine is really quick acting, but it's going to have a quick offloading time. So for paramedics, if we give ketamine IV, 30-second onset time, but it's going to be gone in about 7 to 10 minutes. IM or IN ketamine, it's going to take 5 minutes, but that could last up to 30 minutes. Here's where nitrous oxide fits in. So again, that 30-second onset time, 5 minutes of effect. So very, very quick acting. It's going to be one of our quickest medications. It doesn't require an IV, but it's going to come off really, really quickly. So again, thinking about all of our implications of it, it's a fast-acting analgesic, but it's also our shortest-acting analgesic. It doesn't require a needle. You don't have to inject the patient with anything. So it's going to be a really comfortable medication for the patient to receive. But it's not going to be fit for prolonged transport times. We've got a couple of different issues with it. A, it just doesn't last very long. B, we only have a limited amount. The small little tanks of nitrous oxide that we carry in the ambulance have about 30 minutes worth of nitrous oxide. So you can only administer it for about 30 minutes. Of course, you could carry another tank and switch it out. But it's not a great medication to administer to somebody for these really prolonged transport times. That's when we need to shift to something that's more long acting. And it's not as effective as opioids or ketamine for severe pain. So again, we got somebody who's really, really in a lot of pain. You're still going to want ALS for these people. You're still going to want to give them opioids or ketamine for those patients. So nitrous oxide, in my opinion, is a great addition to our toolbox. I find, and a lot of people find, that when we get a new toolbox or a new tool in our toolbox, we either have some aversion to it because people don't know how to use the medication, or use that tool, so there's some aversion not to use it, or people will overuse that medication. And obviously, both of those can be issues. So not everybody is a great fit for nitrous oxide. You should understand that it's got its limitations, and you should recognize those. And you should understand that nitrous oxide is not an automatic replacement for ALS and opioids. It may be for quite a few patients, though. For quite a few patients who are in pain from things like fractures or just, mild, moderate pain somewhere where we don't have concerns for air-filled spaces or increased intracranial pressure, then yeah, this is going to be a great medication. We may decrease the need for ALS. We may decrease the need for opioids. And I'm sure that all of us would love to have that. I'm also hopeful that this medication is going to increase the amount of times that we administer pain management. There's study after study showing that EMS does not treat pain well. The EMS is not aggressive enough when it comes to managing pain. There's oftentimes an attitude of pain never killed anyone, despite lots of evidence saying that it definitely causes harm, long-term harm, if somebody is in uncontrolled pain for a long time. So I am hopeful that the addition of this tool to our toolbox will increase the amount of patients receiving pain management from us. We understand that teratogenicity is a concern with nitrous oxide. Something to keep in mind is that in the UK, NitroNox, which is again a 50-50 mix of nitrous oxide and oxygen, the same mix that we're using, is used with pretty good, moderate success for labor pains in the UK. It's a pretty frequent treatment for women who are in labor. I'm not really concerned about teratogenicity if the baby is coming out. Personally, I'm not worried about that at that point. I don't think that we're going to cause a whole lot of fetal harm in that time period with nitrous oxide, at least when the baby's coming out. So if you've got somebody who's in labor, yeah, this could be a really good medication for these people. Just keep it in the back of your mind. As far as procedural sedation, we don't have nitrous oxide built into our procedural sedation protocols, but you could absolutely call medical control if you think that would be a good medication for procedural sedation. Keep it in mind. Now, it could be very useful for, okay, let's say you're an AEMT and you're doing a patellar dislocation reduction. All right, it's going to be a quick thing that I do, and then I'm going to splint the patient's leg, but it's probably going to be painful while I'm reducing that patellar dislocation. Hey, okay, I can give my patients some nitrous oxide, take care of their pain while I'm doing it, keep their mind off of it while I'm doing it, and then it's going to be gone quickly, right? I'd say that that's a great medication for that. Or let's say you're a critical care or even an AEMT, and you've got somebody who's very adverse to IVs, or let's say you've got a kid who does need an IV for whatever reason, and they're really anxious about that, and they're scared of the pain from it. Well, unfortunately, we don't have topical anesthetics, right? We don't really have lidocaine spray that we can put on a puncture site. But we do have nitrous oxide. We could use that as procedural sedation for a quick procedure like that. I'm not going to use nitrous oxide for those who are critically ill, right? And I'm also not going to take the time to set up my nitrous oxide system when I have a patient who needs a cardioversion. So it's not going to be a great medication for those who need a synchronized cardioversion, for those who need transcutaneous pacing. They don't use this medication alone in the OR. This isn't a medication that we're using for intubation. We're not inducting a patient with nitrous oxide to intubate them in the field. That's not how that's going to work. I'm going to be using this for patients for procedural sedation for very small but uncomfortable procedures, or not small but quick procedures that I need. But again, it's not built into our procedural sedation protocol. So if you're going to use it for procedural sedation, then you should be calling medical control for that option. For anxiety, there's no anxiety protocol in New York State. Sometimes people stretch that definition to kind of the agitated patient protocol. Understand that anxiety reactions are symptoms, okay? So anxiety itself is a symptom, not in and of itself a disease. Now, the underlying disease could be generalized anxiety disorder, but understand in our setting in the field, anxiety is a symptom of multiple different conditions. Hypoxia, hypercarbia, MIs, anything, major pain, anything like that can make somebody anxious. So you need to figure out, hey, is this anxiety because of generalized anxiety disorder, or is this anxiety because of another medical issue, and rule out other medical issues? You should also understand that there are adverse psychotropic effects. You could produce hallucinations by giving this medication, and it can potentiate the effects of other substances. So if your patient is on any other kind of substance, that's not going to be great because you're going to make that substance act stronger. But if you have somebody who's really, really anxious, hyperventilating, it's a pretty clear-cut generalized anxiety disorder, and you don't really have any concerns that it's going to cause issues, you could consider medical control for administration as an anxiolytic. I'm not sure if the doctor would give you orders for that or not, but you might be able to sell it and you might receive orders for that. It's a medication within your scope. We don't have a protocol for every single patient that we come across, and our protocols have that good disclaimer saying, hey, sometimes you got to do something that's not expressly written. So it's something that you could potentially call for orders for. Our contraindications, our actual list of contraindications here. So our absolute contraindications are potential air enclosing spaces. If you have any indication that your patient could have an air enclosing space, you should not be giving this medication. If your patient has a potential increased intracranial pressure, do not give this medication. Somebody who's already hypoxic, we shouldn't be giving it to them. Those who are critically ill, those who have severe cardiac disease, those who have severe psychiatric disease, or those in the first trimester of pregnancy, you should not be giving this medication to them. Our relative contraindications, abdominal pain, just keep in mind that potential for air enclosing space, and anybody with abdominal pain or upper abdominal pain usually, remember nose to navel for cardiac disease. If you haven't done a 12 lead to rule out the potential for an MI and the patient has upper abdominal pain, they could be having a STEMI, right? And this could be a severe cardiac disease. You're not going to give this to somebody who's having an MI. There's no, I looked at studies regarding giving it during an MI, and there's no real good studies saying whether it's going to be beneficial or harmful in the setting of an MI. If your patient has a potential for pulmonary hypertension, so they've got COPD, they've got CHF, they've got a pulmonary emboli, not going to be a great medication for them. It's relatively contraindicated in the second and third trimester of pregnancy. If your patient has a history of a vitamin B12 or folate deficiency, probably not the best medication to give them. Might be okay if they're taking supplements though, right? So if you're looking at their med list and they take vitamin B12 or they take folate or they take Renovite or something like that, you could at least say, are you actually taking your medications? Figure out if they're compliant with it, and then maybe it would be okay. You might want to call med control first. Or if somebody has altered mental status, your patient has to be able to self-administer the medication. So if they've got altered mental status, it's not going to be a great thing. We're not giving nitrous oxide to those who are unresponsive. Again, they have to be able to self-administer, meaning that they need to be awake, they need to be alert, and they need to be able to follow commands. So very similar to when we're giving oral glucose. They need to be able to follow commands so that you can give them that medication and they can self-administer it. Some things that we've considered for our agency. So along with Dr. Wiseman, we had this discussion about what we're doing with Thai EMS. So we feel that unless an ALS above an AEMT is on board and we get IV access, the patient should be transported to the closest hospital. The reason for this is that long-term pain management is going to be significantly better than intermittent nitrous oxide. So long-term pain management could be opioids. It could be nerve blocks that would occur in the ER. It could be fracture reduction that would occur in the ER, or just in general treatment of the underlying cause of pain. So she really, with our discussion, kind of agreed we shouldn't have AEMTs transporting people from Ticonderoga to UVM or Glens Falls with just intermittent nitrous oxide. We really feel that our patients should be getting some longer term pain management on the way to the hospital. So that's why we want ALS on board to give opioids or just to transport to the closest hospital for long-term pain management. Now, this is something for your agency to figure out. We're only going to be carrying one bottle of nitrous oxide on the ambulance at one time. So we're also not going to be able to go a long distance with this nitrous oxide. Your agency can figure out what your SOP is, work with your medical director, figure out what your protocol, your procedure is going to be for nitrous oxide. If the patient's severe enough for the helicopter, nitrous oxide is generally going to be contraindicated. So this was another discussion that we had. So if you've got somebody who's experienced major trauma, there's multiple potentials for air enclosing space. The patient's having a stroke, they could have increased ICP. If they're having a STEMI, they've got severe cardiac disease. Any kind of massive hemorrhage is going to lead to anemia. And that vitamin B12 oxidation would worsen that anemia. So again, with Dr. Wiseman, we figured, hey, if our patient's bad enough for a helicopter, they need something else for pain, not necessarily nitrous oxide. There could be some kind of isolated situation. So maybe you've got like an open fracture on an extremity, the hemorrhage is controlled, but they're in a lot of pain. Yeah, nitrous oxide might be a good medication while you're transporting to the landing zone or something like that. As far as patient monitoring, you really should be doing quite a bit to watch them. So directly visualizing directly visualizing the patient. Again, this isn't the time to be sitting in the captain's seat doing your chart. You should be keeping SpO2 on them at all times. Keep end-tidal on them at least before and after administration. Make sure that you're actually watching the respiratory rate, counting the respiratory rate. Obviously, end-tidal can do that for you. Watch their blood pressure, although it doesn't really have an effect on blood pressure. Watch their heart rate. You may see their heart rate increase a little bit. That's okay. Some of our agency-specific policies I'm just going to run through here so you guys could use those. I'm happy to send documents to anybody who wants them for your agency. I've got all the documents we have surrounding this on my computer. So if you want help with any of these documents, I'm very happy to send them to you. As far as documentation, we put into our IPCR, when I set up nitrous oxide in our IPCR, I set up custom fields for specific information we want, because we're doing QA/QI on every single nitrous oxide chart, at least for the first year that we're administering nitrous oxide. So obviously the time, the administering provider, the authorization, so whether it was med control or standing orders, the indication for it. So I want to know a specific, why did you give it? Is it right leg pain? Is it abdominal pain? Why did you give that medication? What's your indication specifically? The time in minutes that the patient self-administered it, and it should be a separate documentation for each time they self-administer the medication. Their SpO2 at the beginning and the end of administration, we're specifically watching for diffusion hypoxia at that time and any kind of adverse reactions. We've got control logs that are going to be located with our nitrous oxide tanks in each storage location. So the ambulance or our locked storeroom at the station. So we're going to be filling out a storage log anytime the nitrous oxide is delivered. So our oxygen company that delivers our oxygen has nitrous oxide, so they're going to be delivering our nitrous oxide as well. So anytime it gets delivered to the station, we're going to complete a control form. Anytime we move the nitrous oxide to the ambulance, we complete a control log. Anytime we administer it, obviously we're going to do a control log. Anytime our tank gets depleted and we return it to storage, we're going to do a control log. And then anytime we return the tank to the filling company, that's going to be a control log. This is a control log that I came up with. Pretty simple. Date, name, the reason why we're doing anything with it. We're numbering all of our cylinders, and then you're going to have to get a little scale that can measure in grams. And there's no PSI or anything like that on these tanks. So you've got to actually measure the weight of the tank to figure out when you need to retire it, to see if there's been any kind of misuse. And then our seal numbers, we're just using breakaway seals with it. Like I said, we're doing QA for every single nitrous oxide administration, at least for the first year, probably going on after that. We want to see how we're doing with this medication, how many times we're administering it, if we're having any kind of adverse effects. So we're going to be doing internal review, and then it's going to go to Erin at ECH, and it's going to go to Dr. Wiseman. She wants to see every single chart for nitrous oxide so that we can take a look and see how we're doing with it. So with all that said, I've got my sources here. I'm going to bring the system up for you guys for you to look at, and I'll just kind of show you about what it is. So this is a NitroNox system. Okay, it comes in this carrying case. It's not too incredibly large. We were expecting something much bigger. We were kind of freaking out. Where are we going to put this on our ambulance? Where are we going to fit it? Definitely bigger than most of our equipment, but it's probably about the size of a monitor with the whole carrying case. Nothing too terrible. I'm sure that you can find space in your ambulance for it. When you open up the kit, there's going to be a few different things that you're going to need to take out here. So this is the actual system. We've got the nitrous oxide tank already screwed on through the port on the side of the system. This is a mixing chamber, and then it hooks up to oxygen. Now, one of the important things that you guys are going to want to keep in mind when you get this system is that this is the connector, okay? It's a screw connector to oxygen. So if you're gonna be running this off of oxygen tanks, you know, the little portable oxygen tanks, you're gonna need to make sure that you have a regulator that has a screw on it. So you're gonna want one of these screw male adapters on your regulator when you do it. If you're going to hook this up to oxygen on your truck, you're going to need to get a separate adapter. This does not come with the system. We had to go and purchase this on our own. You're going to want one of these adapters. This end plugs into the wall on your ambulance, and then you get a male screw end on the end of that. You're just going to plug this in. This is going to screw on to the onto the adapter, and now you've got oxygen in your ambulance. The mixing chamber has a little pressure gauge on the top of it, and then you've got this little red cap here. That's where the tubing to the mouthpiece is going to go. The oxygen connects over here. You can actually take this oxygen hosing off if you would like to. Oh, no, you can't. I lied. And then you've got your hose to the administration set. So this just pushes right on down. It's going to click into place on top of the mixing chamber. And then this hose goes to a demand valve. Now, you can't do anything with this demand valve, okay? Your mouthpiece or your CPAP mask is going to go right on the end there. And then it's only going to deliver gas when your patient inhales. So they have to forcefully inhale enough to trigger that demand valve and pull air in. And then what we did is we purchased these little mouthpieces. These look like the nebulizer mouthpieces. That's essentially what it is. So we purchased these mouthpieces to administer through. You put that right on the end of your demand valve. So when we operate this, it's important to remember that your chamber needs to remain upright. Okay, this chamber must remain upright the entire time you're administering this medication. So you can't just put this on its side. That can be an issue when you're running in the back of an ambulance. You're not going to be able to put it on its side. It has to remain upright. You're going to go ahead, hook up your nitrous oxide tank if it's not already hooked up. Make sure that you open it all the way. You're going to hook up your oxygen. Make sure that your oxygen tank... That's going to be funny for YouTube. Make sure your oxygen tank doesn't have a massive leak on it. Okay. Loosen oxygen and screw it on. Okay. So now I've got it screwed onto the demand there. I've got my oxygen tank all the way open. And obviously your oxygen tank can go on its side. This tank is empty, the nitrous oxide tank is empty. I'm not giving myself nitrous oxide right now in the middle of the training. Okay, and then we can see that our pressure is up into the green zone. We're okay there. And then your patient is just going to go ahead and inhale. Okay. So there's that little whistle. That's because our nitrous oxide tank is empty. If I were to shut off my oxygen and my nitrous oxide tank was only delivering gas, then I would get more of a whistle. I'd get more of an alarm with that. But since our nitrous oxide tank is empty, it's not going to alarm if I were to shut off the oxygen. It just means that your patient's just going to be breathing room air. Okay, so pretty simple to set up, pretty simple to use. It's going to take a little bit of time. You got to plug some things in and everything like that. I would say that this whole system probably weighs about, with the bag and everything that we carry with it, probably is going to weigh like 10, 15 pounds. And a little bit bulky, so maybe not something that you necessarily want to lug everywhere you go, but it's not too terrible. So, anybody have any questions on nitrous oxide?